Just one more confirmation.
Yes, sir.
Okay, so we'll be discussing chest X-rays today. And as a undergraduate student, we expect you to, have a basic knowledge how to interpret X-rays, and then go about identifying some of the common abnormalities which we, find in our day-to-day clinical experience. So before we start for the chest X-rays abnormalities, let's first discuss how do you approach a normal X-ray. So I hope the screen is visible to everyone.
Yes, sir, it is. Sir, you will be able to see the responses in the question and answer column.
Okay, the questions. Okay, sorry. Okay, so okay, let me expand it. ठीक है. Okay. Okay, so we start with the normal X-ray. Now, once you approach a chest X-ray, there has to be a method to read X-ray, because a chest X-ray on the face of it is commonly done for respiratory problems or maybe a cardiac problem sometimes. But because that is the most common indication of ordering a chest X-ray. However, if you go about reading a chest X-ray in detail, you will find that chest X-rays provide us a lot more information than what it's commonly perceived. Okay, so there has to be a method in reading a chest X-ray, and it has to be in an organized way. Otherwise, there are chances that you may miss things. You may think there will be lesions that you may miss. There may be some abnormalities that are quite visible on the chest X-ray and you may miss. Okay, so our aim is that we should have a method to approach a chest X-ray. Now, classical teaching used to say either you can go from in to out or you can go from out to in. In to out means you can go from the from if you start from the trachea, then say about the trachea, then the heart, then the lung fields, then the bony rib cage, and then as an overall picture. And it's vice versa if we go from out to in. However, a easier way which has come up in recent times is, I'm sure you guys will be aware of the mnemonic which is used in the ACLS guidelines, which is ABCD. Okay, so if you apply that ABCD to the chest X-rays, you will sort of find it easier to interpret and easier to remember what all you have to see in a chest X-ray. So A will be airway. Airway will include your trachea. It will include your two main bronchus. Okay, and so what you should do, if we look at this X-ray, this is the highlighted part is showing the airway. We can see. Are you able to follow my cursor, or is it?
Yes, we are.
Okay, so fine. So if we see, this is the trachea that is to be seen. This is the division of the trachea into two main pulmonary trunks. Not the trunks, two main bronchus basically, the right bronchus and the left bronchus, and this angle is the carina. So this is what the airway constitutes of. This is what you are supposed to see when we say A of chest X-ray. So airway is seeing the trachea, seeing the divisions, and seeing if whether the trachea is in midline, there is some deviation, some pulling towards or pushing the trachea away, whether the division is uh, equal between the bronchus is divided equally, the angle, the carinal angle is fine or not. Is there narrowing seen? Because if, let's suppose, there is a mass which is growing here near the right main bronchus, you may see a narrowing of the bronchus. So this is what the airway majorly consists of: trachea and its major division into the bronchus. Okay. Then we go about assessing the breathing part. B is breathing. Breathing will include your lung fields. So if we go on to the next slide. So this is the next slide. If we see, this is what the breathing part is. Now in the breathing part, what you have to see, whether both the lungs, they are there, are equal in size. They are equally expanded. Ideally, chest X-ray, if I am sure many of you guys must have undergone a chest X-ray yourself, or you may have for your relative. The advice given while you go for a chest X-ray is that you have to hold your breath in full inspiration. So always and always we look for a full inspired chest X-ray film for a better view. In a chest X-ray film, when it is a full inspired view, you will see that the diaphragm is in this shape. However, if let's suppose if it's a mid inspiratory film, or if it's a expiratory film, the diaphragm would be in a straight line like this. Okay, it would be like this. So this is what, once you get a X-ray in your hand, you see, you find that it is in the whether it's a good film or not. After you've decided that yes, it is a decent enough good full inspiratory film, you go for the breathing aspect, and you see that the lungs on the right and the left are almost equal. You compare the apex, you compare the upper, middle, and the lower zones. When we talk about X-ray, it is the zone. When you talk about the anatomy, it is a lobe. So it is upper lobe, middle lobe, and the lower lobe on the right side, and upper lobe and the lower lobe on the left side. That is what is told, is the teaching for the anatomy. However, if we go about chest X-rays, it is usually the part which is above the clavicle is considered as apex. Then first two or three ribs is the upper zone, middle zone, and the lower zone. So this is what comprises in the lung as the breathing aspect. Okay. Then other things that you have to see apart from the breathing is the vasculature. If you go about the vasculature, you will see these markings. Like if you see this X-ray, these are basically bronchial vessels or pulmonary vessels which are there. Okay. So the extent of middle zone is again two. You go about 2 to 3 ribs. So if it is upper, is if I'm saying first 2 ribs or first 3 ribs, the next would be another 3 ribs, and the last one would be the last 3 ribs. So it is 3 to 6, 6 to 9, like that. Okay. Then in the breathing aspect, you have first seen the lung window. You have seen that it is this, both of them are equal. There is no obvious any deformity, any opacity, any some hyperlucency or hypolucency is there. It is appearing equally black or equally white. So like that. So then we see the angles. So then this angle is the Cardiophrenic angle. So both the Cardiophrenic angles have to be looked at, and we look for the whether this is acute or not. If there is some abnormality, there will be a obtuse angle. We will see further with the X-rays. The next angle that we have to look for is the Cardiophrenic angle. So this is the Cardiophrenic angle. I hope everyone is following this. Okay. So we move forward. There's some issue with this. Wait a second. Okay. So this is what you are seeing in breathing. You're seeing the lung parenchyma. You are seeing the angles. You are seeing the lung vasculature and the angles. So these are the things that you're supposed to see in a breathing aspect. Now we come on to the aspect which is the C. C is the circulation or the cardiovascular system. And here you have to see the heart. So let me just skip to this. So here, if we go for the C aspect, C is cardiothoracic cardiac aspect. So we see the heart, and first thing that we have to see in the heart is the cardiothoracic angle. Cardiothoracic angle, any one of you who can say, it's obviously mentioned on the screen, but what is the normal cardiothoracic ratio? Okay, 55%. It ranges from 50 to 55%. Yes, Nilayan is right, 50 to 55%. So how do you measure cardiothoracic angle is also very important. Common mistake what people do is that, wait a second. Like if I say measuring cardiothoracic angle in this, what people do is they, okay, so what they do is that they measure this and then they measure this. So they will say that this is this is the cardiac dimensions and this is the thoracic dimension. However, what one is missing in this is this. In cardiothoracic angle, what you have to see is from the midline, from, if you see, these are the spines which are visible on the vertebra of the vertebra, and if the person is not having scoliosis, what you see is that you draw imaginary line down this spine, then you draw one line towards the right, towards the left extent, and one line towards the right extent. One key aspect which most of the people miss is that this should be 1/3 and this should be 2/3. Are you following? This should be 1/3 and this should be 2/3. If there is a discrepancy in this ratio as well, then we are dealing with some abnormality in the cardiac function as well. Obviously, the ratio would be like this. This is how you measure the ratio. You measure this, you add this. So it is A plus B upon C, and it should be less than 50% or 50 to 55%. However, if it is more than 55%, we define it as cardiomegaly. If this ratio is disturbed, if you say, let's suppose we'll see subsequently if the heart is like this on this side, obviously there is some abnormality that a good radiologist will pick. Obviously, it is not expected at the undergraduate level, but as and when you start seeing more and more X-rays, you will come to know about it. Okay. Then after assessing the size, once you're done with the size, you're fine. Okay. Then we go for the borders of the heart. Uh, any one of you who can tell what does the right border of the heart comprise of? Yes, it is. If you should start again, the more systematic you are, yeah. So one of you guys who are writing, who is saying that it is SVC, right atrium, and the IVC. That is what the right border is comprises of, and that is also what is seen on the X-ray. Right border is still not very clearly marked. You cannot demarcate. Obviously, you can just have a rough idea. Okay, that this part is the SVC, this is the right atrium, and the lower aspect would be the IVC. The more clear markings are on the left side. So if we ask on the left side, what does the left heart border comprises of? Start from the top. Be systematic. Start from the top. Left auricle, left ventricle. Before that, Rahul, before left auricle, before left ventricle, there are two things. Oh, yes, arch of the aorta is the first thing. Yes. Second, this is yeah, the pulmonary trunk, not the pulmonary artery. It is the pulmonary trunk that we say. So this is the arch of the aorta. This is the pulmonary trunk. Sorry, my bad. This is the arch of the aorta. The concave aspect is the pulmonary trunk. This next bulge is left atrium, and this is the left ventricle. I hope everyone has followed. This is the If you can imagine, this would be the arch of the aorta. अगर हम anatomy देखें, obviously that is not visible entirely on this X-ray. It may be visible in which condition? The arch of aorta can be completely visible in which condition on X-ray? No, not coarctation. No, not TGA. Arch of aorta if I am asking, it would be visible on X-ray. What should be there? Aneurysm may or may not be. Elderly, yes. In elderly, what is the condition that will lead to the visibility of arch of aorta? Atherosclerosis, you're getting close. What I'm saying is, if you just apply the basic knowledge of radiology, uh, what if anything to be visible on X-ray, it has to contain calcium. Yes, calcified media, calcification, exactly. So that is what I'm saying. In elderly, usually what happens is that there is calcification of the arterial walls, and the arch of aorta can be visible on the chest X-ray itself. Now, anyhow, that is an abnormality. Yeah, Monckeberg calcification is one of the types of calcification that would be there. That's good. So we'll be seeing the arch of aorta. We'll be seeing the normal pulmonary trunk is concave. This is the pulmonary trunk. Then the left appendage, you can say left atria is usually not visible. It's the left auricle or the left appendage, and then left ventricle. Okay. So then we move. Then one more thing in the circulation that you have to see is the hilum. So for hilum, I'll have to go to the previous slide. Are you guys able to see the light bluish coloration and the yellow lines? Okay, perfect. So this light blue is what the hilum is, and this is the angle. The angle that we talk about, that hilar angle is, it's the hilar angle is increased or it is decreased. So this is what the hilum, and we know by anatomy that hilum consists of the main bronchus. It consists of the pulmonary arteries. Okay. And one more thing, what are the three constituents of hilum? One is the main bronchus. The second part is pulmonary artery. What is the third aspect? Lymph nodes is okay, fine. One more vessel or a vascular structure, which I'll say. Yeah, pulmonary vein. Yes. So pulmonary vein and bronchial vessels are not that prominent in the hilum itself. They are found more in the periphery. Uh, which hilum is higher? Which hilum is the right one? Are you sure? Anyone else who have a different answer to that? Okay, yes, it is right only. Uh, so the right hilum is slightly higher, but on an X-ray, the difference will not be that much appreciated. So you have to basically see that which whether both of them are at the same height, both of them are looking equal. Uh, okay, so this is what we talk about. So we are done with A, we are done with B, and we are done with C. Now we go to the D. What does D stand for? D stands for basically disability, or it's basically a way of thinking any fracture, any bony fracture. That is what you're supposed to see. And the fractures would include a clavicle, which is visible, or you will see at the rib cage. So this is the clavicle on both the sides. You have to see the rib cage. That is what is visible as for the fractures. Markings, I am not getting. What are you asking? Okay, how to differentiate between normal and abnormal vascular markings. We will see in further X-rays. See what right now what we are showing is the normal X-ray. If you follow this, because this is the most clear, this is a normal marking. This is what you're seeing. It is normal marking. These are the normal bronchovascular markings that are visible in a normal X-ray. In which condition do we know that there is, okay, we'll come to that, Swati. Between AP and PAView, I'll just tell you. Uh, so what I was asking, in which condition are you expecting to see this prominent vascular markings in the upper zone? Bat winging CHF is one of the conditions. Anything else? Heart failure, okay, that is the same thing. Anything else? No, TB is not right. Pulmonary hypertension is not right. Chronic eosinophilic may not be. No, cancer is not right. Pneumonia is not right. Common thing, a cardiac condition, no COPD, no MS. Yes, MS. Spurge, I think, said MS. So yes, in mitral stenosis, there is cephalization of the pulmonary veins. We'll see in the X-ray further. Don't worry. So Swati was asking, how do you differentiate between a chest X-ray and a PA view or a AP view? So all these X-rays that I have shown till now are basically PA views. In PA view, what you have to see is, I'll show you in a, I think, different X-ray, not this. Okay, now even in this X-ray, in this lung field, are you finding any aspect of the scapula? The medial border of the scapula, if it is, what happens is when you go for an X-ray, you are asked either you hug the chest X-ray machine, so your scapulas are retracted. Okay, so that is why in a PA view, the rays are coming from your back and your anterior aspect is opposing the chest, the film on which this will develop. Your scapulas are retracted in a PA view. However, if it is a AP view, that is done in patients who are bedridden and cannot be mobilized. Wait a second. In MR, wait a second, I have a question. In MR, a jet of blood may enter into specific anomaly that can cause a. See, the very statement that you are writing here in MR, a jet of blood may enter. Sorry. Okay, I may have missed it. Yeah, so it can cause. So this is something which is possible. I am not saying that MR cannot have the upper zone congestion. I am not saying that. But the common answer would be a mitral stenosis. Once you go through the pathologies of mitral stenosis and mitral regurgitation, you will come to know why we are talking about why in MR it may be a possibility, but however in MS, in a classical MS, in a patient who is having MS for, let's say, last 3-4 years or 5 years, will definitely have cephalization in the upper zone. So where was I? I was telling you about the uh, so the PA view and the AP view. So in PA view, we will have the scapula which is retracted. In AP view, what you will have is that the medial border of the scapula will be visible on both the lung fields. You will find soon. I'll show you the further X-rays, and you will find the other drawback of AP view is that you will not be able to comment on the mediastinum and the cardiothoracic ratio because that is abnormally enlarged in a AP view. We will see further X-rays and you will come to know. So once we are done with, if we are talking about the disability for D is for the the rib cage. You have to see the rib cage. You have to follow. Let me show you. So these are the posterior aspects. These are the posterior ribs. You're following this. These are the posterior ribs, and this is what the anterior ribs are. So this is what the anterior ribs are. Similarly, on this side, anterior ribs, anterior ribs, anterior ribs. These are posterior ribs. Okay. So that is what you have to see in the bony cage. This is the clavicle, and this is the first rib. So now we move on to the abnormalities. Okay. Okay. So, sorry, one more question. Why posterior ribs are more prominent in PA view? Why posterior ribs are more prominent in PA view? In PA view, what is the structure which is better seen? Yes, the anterior structures, the structures which are closer to the film are better seen. So if you go about the PA view, wait, I how do you say that this is more prominent? I'm not, it is the same thing. It is the ribs coming forward, and the thing that is there is that in posteriorly the rib is completely seen. What you are misinterpreting is from the prominence is not, it is not that the posterior ribs are prominent. The thing is that the anterior rib comes here, and then this is the cartilage. So this cartilage is not visible on the X-ray. That is why you are not able to follow the anterior rib completely to the sternum. The sternum is not visible here, and the cartilage which is there is not visible. So that is why the anterior ribs come and end here, and you are not able to follow it completely. It is not that they are not prominent. The prominence is there. It is not that anteriorly it is more prominent or posteriorly it is more prominent as regard as the rib is concerned. It is about the structures which are better seen. Okay, so now we move on to the abnormalities. What about this chest X-ray? What is the abnormality? If you go by the A, B, C, D that we have discussed, is A fine? Sorry, I missed it. Don't jump to the diagnosis. Right upper lobe consolidation is fine, but yes, go step by step. Is A fine? Yes, A is fine. You can see the trachea. There may be slight disfiguration of the right bronchus. I agree, but if you see the trachea is fine and it is central, so A is fine. Now, if you go to the breathing aspect, you can very well see that B is on the right side. We are seeing that the opacity is there, which is not there on the left side, and it is the opacity is a homogeneous opacity. Wait, why is this not expanding? Okay, so there is a opacity which is homogeneous, and as I think one of you guys pointed out, it is right upper lobe consolidation. Now, in this consolidation, you are unable to see any areas of breakdown which is there. It is a patchy consolidation. The most common organism causing upper lobe consolidation is no, not TB. Strep pneumoniae, no. Can be possible. I will not deny. Strep pneumoniae, yes. Then Klebsiella, unlikely. Staph does not cause. Staph is usually disseminated, causing more of bronchopneumonia. Strep pneumoniae or Hemophilus influenza. These are the two common organisms causing lobar pneumonia. One more feature which can be visible is not visible in this X-ray is a air bronchogram. What happens is once, as you know the pathology, once the consolidation is there, there is exudative fluid in the alveoli. Now, when the alveoli are filled with exudative fluid, that is what you're seeing on the chest X-ray. There is opacification. The air which is reaching through the respiratory bronchioles or the terminal bronchioles can sometimes be very well picked on the X-ray as black lines, and air bronchogram is not visible in this X-ray, but it is one feature which you can find in a consolidation. So apart from that, circulation wise, we can assume that this is fine. There is still, if you see that the right side is slightly more, but the major abnormality that in this X-ray would be a right upper lobe consolidation. So then we go to this. Okay, now in this X-ray, again, A is fine. What do you see in B? Right lower zone. Okay. Yeah, don't go to the hydrated cyst. Again, Rahul, don't jump to the diagnosis. Right lower zone is fine. What is the issue? We are talking about the previous X-ray, as one of you guys pointed out that there is some problem in the right lower zone. Right lower zone is fine. Right lower zone, what is the issue? Pushkar. Yes. Okay. So we come on to this. Yeah. So again, airway is fine. If you go for the breathing, what you're seeing in the right hilar region is only the up. If we talk about this X-ray, the hilum is slightly distorted in this region because of the upper lobe consolidation. It is not a classical Silhouette sign, but Silhouette sign is commonly attributed to the cardiac borders. But this, this, if you compare this hilum to this hilum, you will obviously see that there is some opacification. So that could be a possibility because either the opacification is extending to this region or it is sort of a Silhouette sign. So now we go on to the next X-ray. So in this X-ray, we are seeing in the breathing aspect that there is this cavity which is lined. If you see, this is the wall. Sorry. So this is the wall of the cavity, complete wall. There is opacification, which indicates that there is fluid. Then, if you see that there is, however, there is air here. So obviously, as you guys pointed out, there is air fluid level, no doubt about that. So air fluid level is there. The cavity is a thin walled cavity. It is not a very thick walled cavity. It is a thin walled cavity, but it is a huge cavity. So now we go for the differential diagnosis. What could be the possible differentials? Pneumatocoel in Staph aureus is okay. TB cavity, yes. ABPA is slightly unlikely. Lung abscess is fine. Hydrated is fine. Wegener's with secondary infection, yes, rare. but Wegener's will not have such a huge cavity. Okay, so now if we say lung abscess would be one, pneumatocoel in a Staph aureus would be a second, a tubercular cavity third possibility, especially in India. Tumor with cavity, very unlikely. Such a huge tumor is very unlikely. And because if you go about the size, if let's suppose the size of the cavity was a smaller one, you can still expect that the tumor is there and there may be a cavity inside, but it is again a rare possibility. Wegener's with secondary infection will have multiple cavities. A single cavitatory lesion in Wegener's is very, very rare. And ABPA will not be like this. ABPA is different. Okay, so these are the common differentials that you should be aware of. One is abscess, one is tubercular cavity, one is pneumatocoel. Okay, so these are the things that you have to. So cavity में नीचे fluid है, but ऊपर तो air है, तो abscess में. See, that is what the thing is, that in a lung abscess, sometimes if it has a connection with the bronchus, it will have a air fluid level. There may be a lung abscess where it is just completely uh, okay. So Sparsh, what the issue is that, see, whenever there is a abscess may, it cannot be a complete opacification, because what happens is lung abscess is defined is that when there is destruction of, okay, so if we go into further details, when I talked about the previous X-ray, which was a upper lobe consolidation, in upper lobe consolidation, what we are finding is that the architecture of the lung is still maintained. What is happening is that your alveoli are intact, your the respiratory tract is intact, but there is fluid in the alveoli, there is exudation in the alveoli. However, if we talk about lung abscess, what happens in lung abscess is that I'm not saying that, okay, if we talk about this, that is a huge destruction, the काफी ज़्यादा area has been involved. Now, what happens in lung abscess is that your architecture is also destroyed because of the bacteria, because of the organism. Your alveoli are distorted. Basically, they become a common cavity. That is what a lung abscess is. And then it is filled with exudation. And it will definitely have some connection with the bronchus. That is why you will always find a air fluid level in a lung abscess. I hope it is clear, Sparsh. Okay, so we move on to next. Okay, okay, so now we come on to this X-ray. First, what about airway? Yeah, trachea is deviated to right. It is deviated to right. It is deviated. Then, if we talk about airway, we are not able to follow the left bronchus. It is not visible. What about the breathing part? If we talk about the lung cavities, the lung fields, you are able to see a black picture on the right side, but the left side, it is only limited to this. Right lung, how come right lung has collapsed? If the right lung would have collapsed, would you been able to see this completely? Yes, left CP angle is obviously not visible. Left atelectasis is not the correct wo. See, the point is there is, yes, cardiac border is not clear. Just hold on for a second. Wait. Okay, so yes. So where were we? Yeah. So we are talking about, we are able to see slight aspect on the left side, but rest of the areas is opacified. So this X-ray, left-sided pleural effusion empyema, yes, you can keep one differential as that, because that will explain your mediastinum is being shifted to the right side, your trachea is being pushed towards the right side. Anything else? Yeah, hemothorax, see, it is hydrothorax is equal to pleural effusion, pyothorax is equal to empyema, and hemothorax is just another way of saying blood in the pleural cavity. So all these three things are fine. This is basically one differential only. There is fluid in the pleural cavity. A massive effusion is there, which is shifting the trachea to the right side. Had, as one of you initially you were saying that the right lung has collapsed. If the right lung would have collapsed, the trachea would have been shifted to this left side. But how do you explain this opacification on the left side? So the another possibility in this X-ray can be that it is, apart from the effusion, as you guys said, there may be effusion plus a consolidation. Consolidation is there, which is obscuring the cardiac border with sympneumonic effusion, and because of this effusion, it is being pushed to this side. Is it possible with that this could be a left collapse consolidation? What would have been the case had it been a left collapse consolidation? Yes, the trachea would have been in midline. Yes, trachea would have been ideally in midline or maybe towards the left. That is why a left collapse consolidation is unlikely. It is most likely pleural effusion with the underlying consolidation. Okay, so, and especially it's again a okay, I'm not sure you will be able to make out in this. We'll see in further X's. This is again a AP view, but we'll see in further X-rays. It would be better appreciated there. Okay, so this X-ray. Now compare this X-ray. What is there in this X-ray? It is again a AP view. Yeah, see, again, it is, if it is only effusion perinethi, there are chances it is again dependent on the involvement. See, if there is effusion on the left side, the cardiac border will not be that much affected. Effusion may be very huge. However, on left side, if it is a massive effusion, you may not be able to appreciate the cardiac border. It is not necessary that a consolidation has to be there for the cardiac border to be obscured. But as you guys put forward, in this X-ray, another differential could be a consolidation with sympneumonic effusion, apart from left-sided pleural effusion and empyema, as Rahul said. Okay, so, shall we move on to the next X-ray now? Okay, so in this X-ray, describe, it is a AP view. Anyone? Right side fibrosis, trachea, midline, not really. This is the trachea. Right lung fibrosis. Again, I am again requesting you, especially at your learning age, you should not jump to the diagnosis. And when we are talking about, and this is the way you guys present in the exam as well, whenever you are put forward a X-ray on your, table vivas or grand vivas, don't just see the X-ray and tell the diagnosis. Even if, let's suppose, you have not been told by anyone, any of your seniors in the exam, okay, that we have put in an X-ray of pleural effusion or a consolidation. If you directly tell that this is the diagnosis, examiner may think that you have been already told. It is not what your knowledge is. So even if you know it and you have not been told by anyone else, you're telling that this is a right lung fibrosis will actually be of no use. You won't be judged on that because the examiner will think that you have already been told. We'll ask you, yes. So Nilayan has written patchy right side consolidation. Possibly thymus can be seen overlapping the medial half of the right lung field. Okay. Yeah, left lung field appears to be collapsed as no bronchovascular markings can be. So Nilayan, that is a very good thing that you have picked up, that no bronchovascular markings are there on the left side. However, if you say, sorry, yeah, so Shalu is absolutely right. The point that I was trying to make, if you're not seeing bronchovascular markings on one side, and then you're seeing that the trachea has been deviated to other side, the only possibility left is pneumothorax. Left lower lobe collapse, the right clavicle seems fine if you follow. I don't think that there is a fracture. We will come to the D part later, Ria. We first clear the airway and the breathing part. It is a left pneumothorax with shifting of the trachea on the left side. However, the right side is also not completely clear. What we are seeing is that there are small opacities, patchy consolidation on the right side. Also, one more thing that you guys will notice is that the cardiac border is complete. The heart is completely shifted towards the right side. You are not able to see anything on the left side, which is again suggestive that there is something on the left side which is pushing the upper as well as the lower mediastinum towards the right side. So this is a classical X-ray of a pneumothorax. Yes, left pneumothorax can explain the mediastinal shift. That is what I was trying to put forward in your previous answer question that you had put forward, that left lung field appears to be collapsed is not the right statement. The bronchovascular markings cannot be seen in the left lung field, which is indicative it is a pneumothorax because the mediastinum has been shifted to the opposite side. Okay. Anything else in this X-ray? Yeah. So one of you guys, yeah, Ria was asking whether there's a fracture in the right clavicle. If you trace this clavicle till the time which is visible in this film, I don't see any break in the periosteum on both the sides. It seems fine. Okay, shall we proceed? Okay. Okay. So okay, now this X-ray. What is that circle thing on the left side? Wait. You're talking about the previous X-ray, Shalu, right? Okay, so you're saying this. See, if you're saying, okay, you're talking about this. If this is the collapsed lung, if you're talking about, then the trachea should have been shifted to this side. The trachea is going towards this side. Collapse will be toward the deviation will be towards that side. Okay. Okay. So now we come on to this. What is the abnormality on the right side? Right side, as we discussed, it was the patchy consolidation in the previous X-ray that I'm talking about. Okay, now yes, airway is being shifted towards the left is right. Homogeneous opacity in the left lower and the middle zones, probably air fluid level present, can be pyothorax. Okay, so first we say, sir, there is a deviation of the trachea towards the left side. Now, if you compare the breathing, if you come to the lung fields, compare the upper zone, this and this, the bronchovascular markings are there on this side, not on this side. What could be a possibility? Yeah, again, see, uh, the diagnosis is fine, but how do you justify that diagnosis? If it is a hydropneumothorax, why the trachea is shifted to left side? It is a hydropneumothorax. Definitely, it is a hydropneumothorax. So as I was telling you, the breathing, if you compare the lung fields, yes, collapse of the left lung has happened. What is the thing is that there is no markings here. The lung may have collapsed behind this. It is again not visible. This is entirely a pneumothorax, and beneath it is all fluid. It could be a pyoneumothorax or it could be a hydropneumothorax. Commonly, we say it's a hydropneumothorax with left lung collapse. Common conditions in which the right side is absolutely fine. The right CP angle is absolutely fine. Heart border is again not visible because there is fluid. So as one of you guys pointed out, whether if let's suppose there is a pleural effusion, can the cardiac border be hidden? Yes, it can be hidden. So conditions which can cause hydropneumothorax or pyoneumothorax. Compensatory emphysema will not push the trachea to the other side. Compensatory emphysema happens. Uh, that too happens in long-standing diseases in which the opposite lung is restricted. Infection and malignancy. Okay, so infection is correct, but then we have to be more specific. But which malignancy can cause a pyo or a hydropneumothorax? I am not aware of any malignancy which can present like this. Thoracocentesis done wrongly. Okay, yes. Thoracocentesis, uh, say you may have a pneumothorax, but to get hydropneumo is slightly difficult with thoracocentesis. Trauma is fine. Trauma with superadded infection is fine. Yeah, infections, anaerobic infections. What about tuberculosis? Can tuberculosis not cause hydropneumothorax? Aerobic infections usually do not cause pyothorax. Can, it is not absolute voki that it is not possible, but usually anaerobic is more common. You guys are missing tuberculosis. Tuberculosis is one of the commonest causes of hydrothorax or hydropneumothorax seen in bronchopleural fistula. Is you cannot say in this because there is no ICD inserted first of all. So once you have a intercostal drainage tube inserted here, then only the chances of bronchopleural fistula increases. De novo BPF is very rare. Yeah, it is a common complication of tuberculosis, but it is very rare uh, that without a ICD a BPF develops. I don't have the X-ray of BPF as well, वैसे तो. Anyhow, no issues. So this is what we are finding in this X-ray. There is a pneumo, there is a hydropneumothorax with the collapse of the left lung. Etiologies you guys have mentioned, trauma can be one of the etiologies, infection, anaerobic infections, tuberculosis. Okay, now one more thing which is I would say not a very characteristic marker, but no, see, I would say on the right side, the markings are normal. I would not say that they are excessively prominent. In this region, you may say to some extent, but otherwise these markings are normal. It is absent on this side. That is why it is looking more prominent, but however, it is not that prominent. So coming to one point that I wanted to put forward for you guys is that uh, in clinical scenarios, if you guys, many of you guys may opt for medicine in future. So when you see a case of hydropneumothorax, what you see is one soft marker of telling whether it is fluid or it is pus is if you are able to see the ribs. See, in this opacified region, if you're able to see the ribs, you're likely dealing with a hydropneumothorax. However, if it is the ribs are also not visible, then it is most likely a exudative thick pus which is there. That uh, management changes, the antibiotic coverage changes. So it is one of the signs which you can just pick on the X-ray and start the treatment empirically. Obviously, once you have the report from the fluid, uh, that will confirm your findings. But till that time, the treatment can be started. Okay, so we move to the next X-ray. Okay. Okay, describe the X-ray. Good. Trachea is deviated to left. Yes. Pull to left. Apart from that, whole mediastinum has shifted to left. Yes. Is it only shifted to left? Has it gone up as well? Yes, the right bronchus is pulled to left. The cardiac shadow is to the left. Yes, left and up. Rahul, very good. The mediastinum and the cardiac is being pulled up. Now, why has it been pulled up? What could be the cause of pulling up of the? If you see this, some tumor before that. Yeah, fibrosis. This is the right hemidiaphragm. You're not able to go for the left hemidiaphragm. This very reason, because there has to be some fibrosis somewhere here, which has pulled up, which has pulled the trachea towards the left, and it has pulled the trachea towards, it's pulled the trachea up. So yeah, silicosis can cause fibrosis, tuberculosis can cause fibrosis, sarcoid can cause fibrosis. Upper limb fibrosis would be the first. Adhesion is not right. Uh, Upper limb fibrosis would be the first differential. Tumor will not have such a drastic drift of mediastinum. What tumor does is that it presses on the airway, or sometimes it could be a possibility that there is a tumor here which is pushing the trachea towards the left side, but it will not cause this. So here the commonest commonest or probably the only differential would be a fibrosis because of the causes that Nilayan has mentioned. And there are some other causes as well. They could be post, after infection sequelae, post pneumonia sequelae. Then the common thing that we guys are now facing these days for last 1.5 years is COVID. So that could also lead to such kind of a picture. Obviously, this is something which has been taken beforehand. So that could be the possible etiologies. Anything else? Any abnormality in the bony part? No, the rest is fine. Anything else that you can find on this X-ray that may look as something anomalous to you? Apart from this, apart from the fibrosis and the pulled up of the mediastinum and the cardiac shadow, everything is there. Apart from that, anything else? Vertebra shifted to right. Not not very classically. Yeah, you can say slight shift is there. No? A drain has been inserted. It's not entirely a drain. This must be a ECG lead. This is the anomaly that I wanted you guys to pick up. This is most likely a ECG lead. Okay. So okay. So now we come on to this X-ray. Sorry. Yeah, this X-ray. Airway. Is it fine? Shift towards right, no. Slight, not very classical. Not very classical. Anything else? Airways, more or less fine in this patient. Okay, what you're saying, bilateral patchy consolidation, most likely METs. Bilateral patchy consolidation is fine. Airway looks okay. Stippled appearance on lung field. Miliary TB, good. Multiple small calcification throughout the lung. Patchy opacity, bilateral. Miliary TB, yes. Miliary TB. So here what we are seeing, airway is fine. However, in both the lung fields, you're finding very fine. It is not patchy consolidation. Yeah, it is very fine consolidation which is there. Very small tubercles, if you would say, or millets, you would say. So that is there, and it is there in the entire lung field on both the sides. So the most common differential for this would be miliary TB. However, that is what is expected from you. If you're not able to tell this, then it would be the viva won't go further, obviously. However, if you say that endemic mycosis is very unlikely, if we go further and I ask histoplasmosis, will have slightly bigger. See, wherever you keep TB as a differential, obviously chronic fungal infections do become a differential. But this is a classical picture of miliary tuberculosis. However, you can confuse it, and uh, another clinical condition can present like this as well and cannot be TB as well. Anything else apart from fungal infections? Reticular opacities would be bigger, ILD. DAH, yes, DAH is good. What is DAH? Anyone else apart from Nilayan? I hope everyone gets what DAH is. Yeah, diffuse alveolar hemorrhage. So diffuse alveolar hemorrhage is can present like this on this it could very well be a X-ray of diffuse alveolar hemorrhage. Now the differentiating feature would be clinical scenario. If a patient who is presenting to you with a normal oxygen saturation with minimal findings, may or may not, there may be some crypts, but the saturation is normal, it is highly likely that this is tuberculosis. No, it is not ground glass opacity. Ground glass opacity is different. Uh, that ground glass opacity and reticular opacities are one of the almost seen commonly in ILD. So what I was telling you was that yeah, GGO. See, ground glass opacities is better picked on CT scan. You are right in that. Ground glass opacities is a term which is picked better on. But however, if there is extensive ground glass opacities, you may find them on X-ray as well. However, if you say that, especially in such a COVID scenario, when we had people who were having normal X-rays, you cannot absolutely rule out that the patient may not be having mild ground glass opacities on normal X-ray. The CT may pick up those ground glass opacities. So all those mild categories, the CT severity scores that you may have heard of, going up to 6, 7, 8, may have a normal chest X-ray. So yes, GGO is a CT finding, but it can be picked on X-ray. If it is, let's suppose, a CT severity of 15, you will find ground glass opacities on X-ray as well. So my point, which remained incomplete. So if the patient is presenting to you with a normal oxygen saturation, it is likely to be miliary tuberculosis with the obvious definite history of constitutive symptoms like loss of appetite, weight, and fever and all. However, if the patient is presenting to you having shortness of breath, having this difficulty, having this X-ray, and the saturation is dipping down to 80, 70%, you always consider diffuse alveolar hemorrhage. And one of the commonest causes of diffuse alveolar hemorrhage, no. ARDS, no. Shock, no. Good pastures. See, sepsis will present as ARDS. Good pastures, no. It can, but it will not. The presentation good pastures is more of a renal presentation. I'm not saying that good pastures cannot present as autoimmune. I'm talking about which autoimmune. Vasculitis vagina is the correct answer. Chemical inhalation will have a different sort of a picture. It would be chemical pneumonitis. Sarcoid is one of the differentials, but very unlikely to have a sarcoid with such a diffuse involvement. It is vasculitis, basically. Wegener's commonly can present like this, or for that matter, any vasculitis can present as diffuse alveolar hemorrhage. SLE can present as diffuse alveolar hemorrhage. Wegener's do present, and it is if you search for the literature, you may find few case series and all. Okay, so we move on to the next. So is the whole left lung fibrosed in the previous one? Wait. See, in fibrosis, it is you cannot say that the whole lung is fibrous because you are able to find some areas where the air is still there. Cannot say the whole lung is fibrous, but definitely because the mediastinum is pulled up, the upper zone is definitely fibrosed. This may be a middle zone as well, which has been pulled up, or not the middle zone, or maybe the lower zone as well. So we come on to this. This is a fairly easy X-ray. I'm sorry that it is there on the, काफी late है तो it's a very common X-ray asked from you guys. Airway, fine. Airway is fine. Come on, guys. What happened? Airway is fine. The breathing, if you see, you are not able to visualize the right, middle, and the lower zone. Yeah, probably empyema or probably a pleural effusion. Basically, there is blunting of the. It is not a sloping opacity. This is basically the Lee's S curve that you see. So this is the curve. This is the curve. This is pleural effusion on the right side. There is blunting, yeah, and could be probably empyema, but see if you can see the ribs are there, so probably only a hydrothorax. Okay. Okay. Now this cannonball opacity is perfect. Yes. So this is what a metastasis. One of you guys pointed out in this X-ray that Mets due to malignancy. This is not how a Mets would present. Mets would present like this. Why trachea is not shifted in the. See, if you see, the effusion is limited to the lower aspect. So there will be shift of the lower mediastinum. The upper mediastinum may not be involved. Yeah, lower lobe consolidation you cannot rule out. It could be a possibility, but given the you only lower lobe consolidation cannot be there. There has to be effusion because this is not how a consolidation would sneak into the upper area. The blunting of this angle will definitely say that there is fluid between the cavity. It may be a possibility that the lower lobe consolidation is there with the mnemonic effusion. However, only consolidation is not the right option in this. It is consolidation with effusion. That could be one of the differentials, but the first differential would be a pleural effusion. And why the shift is not there? The shift is there in the lower mediastinum. This is shifted to this side. If you remember the normal X-ray, the left border were extending up till here only. However, it has been shifted towards the left side. So cannonball, nothing much in this. Common causes, common malignancies having cannonball metastasis. 2 or 3 examples. Renal is good. RCC has a very common cannonball appearance. Anything else? Choriocarcinoma or adrenal. I'm again not sure. I would say renal, yes. Choriocarcinoma, yes. Ovarian also can do that. Breast, I'm not aware of. It may be possible. Pancreas is unlikely. Adrenal can have adrenal usually have lung mets, but not classical cannonball. Bone, no. Bone cancer, no. Yeah, so we keep renal, choriocarcinoma, ovarian carcinoma, colon carcinoma are the ones which I am aware of. Breast, you guys can check. Adrenal, I think, does not present as cannonball metastasis, or if it does, it may be a very rare presentation. Okay, so thyroid, we are talking about this X-ray only. Yeah, thyroid. Okay, thyroid for cannonball, थोड़ा unlikely है. Thyroid malignancy usually नहीं करता as cannonball. Okay, now coming on to this X-ray. Yes, A and B is fine. No, trachea is not shifted to left. It is basically slightly rotated. This is the trachea. This is the bronchus. Yeah. So if we see cardiothoracic ratio is increased, the cardiac dimensions are also disturbed. This is, if you draw the line here, sorry, if you draw a line over here, this is definitely not 1/3. So this is also increased. This is the ratio is also increased. Tamponade, you cannot be sure, but it could be a DCMP. No, it is not a boot-shaped heart. It is not a boot-shaped heart. We have a X-ray of that. Yeah. So from the only thing, aortic aneurysm, no. For this X-ray, what I would say is that this is A and B is fine. C can there you will see that there is cardiomegaly. MS could be a possibility. Could be a possibility. Yes, it could be cardiomyopathy. Why we have two shadow borders of the heart? Yeah, you are asking about this. So yeah, this could be a possibility. I'll show you another X-ray. Don't worry. Now, see, in this X-ray, you cannot uh, widening of the mediastinum. Yeah, you can say it is widened, but aortic dissection is not the right diagnosis here. The mediastinum is widened. It could be a possibility, but see, because if we follow aorta, you're not थोड़ा सा exposure अच्छा नहीं है, so you're not able to follow the aorta completely. It should be going like this. This is how the aorta goes. This can be attributed to left atria dilation. We will see further in the X-ray. Bronchovascular markings are not decreased, they are fine. The markings are decreased means you are dealing with oligemia, that is seen in patients who have a right to left shunt. We'll go forward. Erase all drawings. Okay, so
we come to this. Now tell me. Yes, it is tetralogy of fellow. First of all, if you guys would have noticed, this is a AP view. Why is it a AP view? Yes, very good, Nilayan, because you see the medial border of the scapula is here. Then it is a classical, one of you guys had pointed out, Saket, in the previous X-ray. This is what a boot-shaped heart is. This is what the boot-shaped heart is. Okay, this is the scapula. And it is a rotated film as well. This is the scapula. Okay, so yeah, but see once again, if it is a AP view, the cardiac ratios should not be commented upon. Obviously, they will be disturbed. It is definitely disturbed, but you should not comment when it is a AP film. Okay, so next X-ray. Okay, yes, Agon string once. Okay, that is a sign. Good, TGA. But apart from the massive cardiomegaly that you are seeing, what else can you appreciate? See, if you compare the X-rays, I'll show you. Wait. See this X-ray. This is also having a cardiomegaly, and see this X-ray. What is the difference apart from the cardiomegaly? Ribs are more straight and parallel. That is what I was expecting. So ribs are more straight and parallel are seen where? No, not in hyperinflation. Till now, most of the X-rays that we discussed were adult X-rays. This is an X-ray of a child, and that is why when you're growing up, yeah, it's an infant. Yes, that is the reason. Uh, in a small babies or infants, and uh, the ribs are more horizontally placed. So that is why it is a young child's X-ray with the cardiomegaly. Could be possible TGA. So these are the X-rays I just want to put forward for you guys to have a view. Okay, so next, now see. Okay, so this is a X-ray that I found online regarding the classical description of mitral stenosis. Pushkal, it is not necessarily that this is a TGA. Like one of you guys mentioned that it is on this. See, as I have been saying in my whole class, do not jump to the diagnosis right away. Always describe what you're seeing on the X-ray. If the examiner asks what is the possible diagnosis, you can put forward the diagnosis. Okay. So don't always jump to say that you cannot only on the, like if we see this X-ray, obviously I say that this is a boot-shaped heart and it is commonly seen in tetralogy of Fallot. But on an X-ray, you cannot say that the patient is having tetralogy of Fallot. Okay, so similarly, you cannot here say that the patient is having TGA. You need other investigations, you need the clinical scenario. But yes, common signs are there. If that are there, then it is more of a indication that it could be a TGA. Okay, so now we come on to this X-ray. This is a classical X-ray of mitral stenosis. What you're seeing, airway is fine, the breathing is fine. Come to the C aspect. Breathing is not entirely fine. You see the yellow, this mark, this is showing the prominent upper lobe vessels, which are there on both the sides. The airway also, if you see the bronchus, the angle is widened, the carinal angle is widened. Okay. Then why the left bronchus is elevated? Because of the enlargement of the left atria. This is the left atrial border. This is the right atrial border. So this is double atrial shadow. As I had discussed in the first X-ray, that the pulmonary trunk is concave. Here you see that this is a convexity outwards. So this is the main pulmonary artery. And then you see that there is straightening of the left heart border. If you see, this is the line that we can draw. So there is straightening of the left heart border. So this is a classical X-ray of mitral stenosis. Any doubts in this? Oh, these are non-specific dot markings. Don't focus on that. One is upper lobe congestion. Okay, both the sides, the vessels are prominent. There is widening of the carinal angle. This is the carinal angle. Uh, can I extend the time? I think it is going to end in a minute or so. So this is the widening of the angle. The left main bronchus is elevated because of the left atrial enlargement. This is the double atrial shadow, the right atrial border, the left atrial border, and this is the straightening. But how do I extend the time? In this, it is showing that it is less. I think it's about to end only. Okay, so it will continue. Okay, no issues. Okay, no problem. We'll continue. So yeah. So I hope everything is clear in this X-ray. Shall I go forward now? Okay, fine. So now we go on to the next X-ray. So this is a very good X-ray of mitral stenosis. Okay, now tell me the abnormality in this X-ray. Yeah, valve is there, agreed. So you can see this artificial valve which is there, bioprosthetic valve. Yeah, sternotomy wires with artificial valve. Very good. So that is what you are seeing in this X-ray. This patient have undergone a cardiothoracic surgery. That is why these sutures are metallic sutures. They are put in patients in which we do sternotomy. Once we cut open the sternum, we have to suture it with a metallic suture, and that is why these will be seen. The two common conditions that is expected from you is, one is cardiac surgery, this basically valve repair surgery. The second thing would be a bypass surgery, coronary artery bypass. In both the conditions, you will have these things. This is a valve, a bioprosthetic valve. which is there. So the next question would come, what should be the INR of the patient who have a bioprosthetic valve in situ? What should be the range of the INR? No, 1.5 to 2 is not right. 3 to 4 is not right. Yeah, 2.5 to 3.5. Yes. So yeah, 2.5 to 3.5 is fine. Some books also say 2 to 3, but 2.5 to 3.5 is commonly accepted. So these are the questions that will be asked. The heart size is fine. There is not much. Baki, the rest of the X-ray is fine. My only purpose was to, show you the uh, bioprosthetic wall. Okay, so we move on to this X-ray. Not really. Okay. So now whosoever gets the diagnosis in this has will only get the diagnosis if you follow the protocol that I taught you. A, B, C, D. Is A fine? Aortic knuckle dilation. Okay, I can accept that, but again, that is, yeah, see, it is not air near the aortic arch. What I was telling you about was that this knuckle has got calcification. You see this? I'll show you. But that is not what I put the X-ray for. That is just another finding in this X-ray that is very good for you to pick up. Air is not there. It is this slight calcification. No lymph nodes, no. So A is fine. B is B fine? Left middle lobe consolidation, yes. Okay, so why are you thinking left middle lobe consolidation? You can see this is the parenchyma which is there, which is fine. Lingula left cardiac border, heart border is not concealed. You can find the heart border. Yes, it is there. It is there on this side as well. Yes. Which fracture are we talking about? Yeah, refracture on what side? Yes, very good. So that is why, see, initially your first 10 responses were limited to Sarthak. Okay, that's good. So Sarthak pointed out first and Sparsh as well. So that's very good. So first 7-8 responses, you were focused only in the lung and the heart. There are times that you will come across, as I told you in starting, that there are times that you will come across where you will get X-rays that are not just limited to lungs and the heart, they're there to the bony rib case as well. So this is a fracture, this is a fracture. So basically multiple fractures are there on the left ribs. Okay, 3 fractures I can make out. There may be more in the lower, we cannot be really sure. So always go look for A, look for B, look for C, and look for D. At least look for these 4 things in the X-ray. Okay, so we then move forward to another X-ray. Okay, what is this? I don't think so. I'll be extending up to 2 because there are now few X-rays only. But okay, so what is there in this X-ray?
Loculated diffusion on the right side. Okay, one differential, right subpleural thickening, good. That is good. So A is fine. Breathing in the lung fields majorly are fine, but you're seeing slight opacification, sorry, on the right lower zone, but you are seeing that this is a convex outwards picture. So this indicates that it is not arising. Don't say that this could be a consolidation. My only purpose of putting this X-ray here was that don't say that this is a consolidation. Reason that a consolidation uh, will not have a pleural base. This is based from the pleural. Either it could be a loculated diffusion that is acceptable, or it could be a pleural based tumor or a pleural based growth or some subpleural thickening. Yeah, it could be. See, again, mesothelioma, it could be. You cannot say that it is mesothelioma on the X-ray only, but yeah, one of the differentials can be mesothelioma. The rest of the things in this X-ray is fine. The bones and everything is fine. Anything else? Any doubt? Shall we proceed? So who is saying that this is a pleural effusion? I am not saying that this is a pleural effusion. It could be a pleural effusion. It could be a pleural based mass as well. So if it is a pleural based mesothelioma, there it would not be any effusion. That you have to confirm through a CT, or you have to do a USG to look for any fluid. Okay, now this X-ray. Here under the diaphragm, very good. So now I have come, now till now we have discussed A, B, C, D. That is there, that is what you are seeing, what the chest X-ray is done for. However, there are times when you will find, apart from the thorax, there are other things that can be picked up in the X-ray. This X-ray is one of the examples of that. Air under the right diaphragm, classical suggestive of perforation and pneumoperitoneum. So that is why I had put forward this X-ray, that sometimes on an X-ray you may pick up things which are not for pneumoperitoneum, the investigation of choice is definitely chest X-ray, but sometimes you may have ordered a chest X-ray for something else and you may find out that there is air under the right diaphragm. Okay, let's suppose I would say that this is not a pneumoperitoneum. What else would it be? What could be the other way of putting forward the question is, what could be the other causes of air under the right hemidiaphragm? Chilaiditi syndrome is good, very good. I hope everyone else is known of Chilaiditi syndrome. See, duodenal perforation is equivalent to pneumoperitoneum. I'm asking anything apart from that. So air under the right hemidiaphragm, one can is Chilaiditi syndrome, which means that the colon is there, right, just beneath the diaphragm. That is fine. Hepatic abscess rupture, unlikely, because hepatic abscess will not be having air inside. Laparotomy, possible. Anything else? Anything else? What if the gastric bubble can be on this side as well? One of the common things that can be there. Okay, so I just wanted to show you one more X-ray. I think it is not there in this. So yeah, I hope it is visible. Now this is the last X-ray of the day. Obviously, you can see the name of the file on the top only. No, I don't have a X-ray of pneumomediastinum, but in pneumomediastinum, I'll show you what happens. Just let me. In pneumomediastinum, you will find a thin streak of hair here, like here. That is what a pneumomediastinum would be like. Okay, so now I don't want you to. We did have a X-ray of cardiomegaly with heart failure. Curly B lines are difficult to. It is more of a theoretical. Oh, you may find what are curly B lines? What are curly B lines? Okay, I agree that they are seen in pulmonary edema, but where do you see curly B lines? Curly B lines are seen usually here. No, it is seen at the base. The like horizontal lines like these. This is what a curly B line is. Like this. This is what a curly B line is. I could not find an X-ray which had a very classical O. That is why I did not show. Okay, so if I say this, okay, what can you see in this X-ray apart from A, B, C, and D? Okay, apart from A, B, and C, is this image visible for you guys? Okay, so now see the X-ray and tell me. A, B, C, I don't need your comments. I am making it easier. What you can see in D and what you can see apart from A, B, C, D. Yeah, it's not classically a PA view because, or even if it is a PA view, this is the scapula are not properly retracted. But yes, you can classify this as a PA view. Don't worry. Australitic lesion in the upper right rib. Okay. Yes, absence of the breast shadow in the left side. So as the name is there on the file itself, this is a patient who had undergone a mastectomy. So this is another clue that a chest X-ray can give you, that this is the breast shadow on the right side, but there is no breast shadow on the left side. And as one of you guys pointed out, that there are lesions on the ribs which are suggestive of bony metastasis commonly seen in patients with breast cancer. This is one of the metastasis that is there. Okay, so any more questions? How do we differentiate pulmonary hypertension and hilar lymphadenopathy? It is, see again, pulmonary hypertension and hilar lymphadenopathy, before just going directly to chest X-ray, it is not easy. You have to basically go for the clinical scenarios, and then based on the clinical history, you go about differentiating. Like if I go to this hilum, so pulmonary artery, if there is a dilation of the pulmonary hypertension, this area would be dilated. If there is hilar lymphadenopathy, there will be nodes here. देखो 309. Okay, so the lesion is here. This is the lesion. This could be one of the lesions. Okay, anything else? Any other doubts before we close it? Okay, so you are asking about the oscillation. Okay, so this is the osteolytic lesion that I'm talking about on the left side. This could be another one. Okay, arrow is not moving. Okay, let me see if it is possible this way. Spotlight. Okay, now is it visible? This is one of the lesions. Is it visible now? This is another lesion. No. Okay, wait. Copy. So, okay, this is one of the lesions which I was talking about. And this is possible another lesion. Okay. I hope now this is visible. We cannot comment on the cardiothoracic ratio in the AP view. We should not be idly commenting. However, if there is gross cardiomegaly, it would be quite obvious. I hope now the cursor is visible. Okay, if I count, yeah, so this is one lesion, this is another lesion. Okay. Okay, so we finish the lecture for today. How about your attendance? How is it done? Okay. So I expect that once you're done with the attendance, Priyansh can send me that on the WhatsApp. Okay. Okay, Priyansh. Fine. Okay. Thank you everyone for your time. Bye bye.